this cohort of EV-201 asked a very interesting question, and a question that involves an evolving landscape in urothelial cancer. The question here was that with the approvals of frontline immune checkpoint blockade in patients with metastatic urothelial cancer who are cisplatin ineligible, an evidence void developed for what to give those patients when they progress despite single-agent immune checkpoint blockade in the first-line setting. One could think about then going to carboplatin-based chemotherapy, although that hadn't really been explored prospectively in the past. Based on the activity and safety of enfortumab vedotin, this agent was tested in this very setting. Patients who were cisplatin ineligible had received frontline immune checkpoint blockade and had progressed. And the response rates with enfortumab vedotin in this context were quite impressive in this single arm experience, with a response rate over 50%, certainly competitive with what we expect with carboplatin-based chemotherapy in the frontline setting. So extrapolating that to this setting, certainly quite competitive. And this really does raise the question, should enfortumab vedotin, which is approved in a different context, should it be used in this situation? One of the challenges with these data, although very important in filling a knowledge gap, is that the space has evolved, or the treatment landscape has evolved, and now upfront chemotherapy with switch maintenance immune checkpoint blockade represents a very standard option. And so the number of patients getting single agent upfront immune checkpoint blockade is probably smaller than it was when this cohort was envisioned. But we know patients still receive upfront immune checkpoint blockade for a variety of reasons, and these data do fill that evidence gap.